Good afternoon, everyone. Thank you again for joining us. Today we're going to present for you a special topic, a burning topic, and we hope you stay tuned until we finish our session. I'd like to say welcome. My name is Dr. Tsaidanish Mkunen. Here I'm joined with Dr. Tadaid and Dr. Ebenezer. They are Yetenaweg team members. So let me tell you a little thing about Yetenaweg, and we will proceed to our session today. So as all of you know, Yetenaweg is a volunteer network and digital health platform. It uses digital health to advance our healthcare system in Ethiopia. So as you can see from this picture, we have got nearly 70 active volunteers who work in different aspects of our work, and we span across 5 different countries. And Yetenaweg is registered in Pennsylvania, USA, as a non-profit organization. And as you can see here, our active volunteers are healthcare students, doctors, specialists, and IT professionals, and nurses with different backgrounds. So Yetenaweg projects and engagements span from health promotion to community engagement, mentorship, as well as medical education. So our today's session, CME, is under medical education. So we are more than a digital platform. We try to prepare sessions for donating blood, and we try to donate some materials for people. And so as you can see here, we had a session on September where we tried to screen the general population, and we tried to teach them about like how they can make their health better. And these are all our volunteers, and this is the session on September as well. So Yetenaweg, in collaborating with ROHA, we have prepared a health article writing competition that occurs every yearly, and in 2000 these are like our winners. This one was from 2021. This one, as you can see, was from 2022. And last year, two of this healthcare, two of the doctors won article writing competition, and they were able to go to Rwanda and attend the session. So for the 2024, you guys can write an article in different languages. It can be in Amharic or for any language, and it will be, if it wins, you get win a prize. Yetenaweg also collaborates with ROHA for research fellowship, and we started with the Anbessa hospital, and we tried to select departments like oncology, radiology, and internal medicine, and give grant for 4 of them. You can see their picture. We give them grant for their research. 2 of them from internal medicine, 1 from oncology, and 1 from radiology. So when we come to Yetenaweg CME, as you all know, it's freely accessible. And for this year, we have planned nearly 28 CMEs, and this is going to be our second CME. And our attendees span from 150 maximum to 300 attendees per session. And this year, unique to this year, we try to start with neurosurgical topics, as well as OBGYN, oncology, pediatrics, ENT, and different surgical aspects. So we collaborate with EMA, with ASCP, and with ESIM for today. Our session is collaborated with the Ethiopian Medical Association. And we try to invite local and international experts on different topics. So after the session, you guys can check our YouTube channel to get the video recording of the session. So you can join our social media platforms and get updates on when the next session is going to be. So to get the best experience of this webinar, make sure to attend the whole session. We check like the time you guys attended. Make sure to fill in the form, which we will be sharing after our guest speaker finishes his talk. And also make sure to get 50% of the questions right. get the certificates, and it will take like 1 to 2 weeks to be sent to your email. The certificate takes 1 to 2 weeks. So I say thank you to that. And so our today's topic is going to be approach to back pain, specifically approach to lower back pain, and it's going to be delivered by Dr. KIBRUYISFAW. So as all of you know, Dr. KIBRUYISFAW is a consultant neurosurgeon who completed his undergraduate studies in Addis Ababa University School of Medicine in 2012. He pursued specialty training in neurosurgery and completed postgraduate training in Addis Ababa University School of Medicine in 2017. Subsequently, he underwent clinical observation and hands-on training at CMC Boler, India in 2017, and has been practicing in different countries. Currently, he is a vice CEO of Lancet General Hospital. In addition to his role as a clinician, he is involved in a number of leadership and advocacy initiatives, as evidenced by his participation in numerous technical working groups and professional societies. He's a researcher with many publications and has contributed to the body of knowledge on various prominent topics. So without further ado, Dr. KIBRUYISFAW, you can proceed to your session. And let's say again, thank you for joining us today.
Thank you very much. Thank you very much, Zaga, for your kind words. Today's topic is going to be discogenic lower back pain, because there are a lot of topics on this lower back pain. And I try to emphasize the most common cause, and usually the diagnosis is usually common. And most of the time it's over-diagnosed and over-investigated. So we try to see the basic approach how to evaluate and manage this lower back pain of discogenic origin. So this is my objective. So mainly we will see on the definitions of lower back pain. We'll try to elaborate the etiologies of back pain and what are the risk factors associated with lower back pain. And we'll try to see the basics anatomy of the spine, specifically the intervertebral disc, which is the commonest cause of back pain. And we'll see the anatomy. Then we will see a basic investigation for our patients with low back pain, including the indication when to send MRI, other imagings or lab works for a patient with lower back pain. Then ultimately, at the last, we'll try to see the algorithm or to see some of the surgical indications for a patient having lower back pain. So these are the topics. So as you all know, so back pain is a vast topic, but specifically there are upper back pain, cervical neck pain, and there is lower back pain. So there is a completely different definition for each. So when we say it's a lower back pain, it's a posterior trunk pain, which originates from the back between the rib cage or the lower costal margin to the gluteal folds. It might be with or without leg pain. So it includes also radiculopathy. So lower back pain is defined as a pain which starts from the lower costal margin to the gluteal fold without the leg. So when we say term discogenic, this means that the source of the back pain might be one or more discs. So that's what we call a discogenic origins of lower back. So as you all know, back pain is one of the most common causes of hospital visits. It's the second most common etiology for hospital visits. It incurs a lot of hospital burden, also economical burden throughout the year. So when you see in the Western countries like in US, the annual economic burden following low back pain reaches in 100 billions, like in 2 to 300 billions. So it's one of the commonest cause of outpatient visit. It's one of the commonest cause of work abstinence and others. So it's the economic burden for the individual as well as the whole country as well. So when we see the lifetime prevalence of back pain, a reported lifetime prevalence is around 18%. That means 80% of us ultimately in our life will complain back pain. So it's a very common And usually the incidence of back pain increase at the age of, starting from the age of 13, it goes on beyond, and it reaches peak at the age of 15 years and above because of the pathophysiology involved in this issue. We'll discuss this one later. So when we see the etiologies are very different, starting from a simple muscular pain to deep down the bones. So there are different causes for back pain. It might be degenerative disease. This might be degenerative disc disease, including degenerative vertebral body disease causing compression to the nerve roots, joints in the spines, or it might be involving the ligaments. So all this might be the cause of back pain. The other things are common incriminations are inflammatory changes. These include infections as well as inflammatory condition like ankylosing spondylitis, rheumatoid arthritis. Infection common in our setup might be tuberculosis, TB spondylitis involving the disc, or it might involve the bones. So these are also common infections. Those patients who have recurrent UTI, they might be also subjected to have a pyogenic discitis. So infections are also one of the common etiologies in the cause of back pain. The others are malignancy, especially malignancy like breast CA and prostatic CA. That's it to be the first and the most top cause of back pain because they usually tend to metastasize into the vertebra, especially on the lower vertebra and the lower part of thoracic vertebra. So patient with malignancy, the initial presentation might be a back pain, or they might present with recurrence with seeding into the bone. So malignancies are also said to be the cause for back pain. The others are metabolic diseases like osteoporosis, like osteomalacia, baguette disease of the bones, and other might be the cause for some injuries like acute or chronic injuries, might be trauma. So these are some of the etiologies that cause back pain. So when we see the anatomy, so these are what we call the spinal functional units, which includes the vertebra above and the vertebra below, with disc in between. Any abnormality that affect these spinal functional units might present with back pain. So when we see the anatomy, this you see the spinal cord, you see the dura, the pia maters, and you see the ligaments, the different ligaments. This might be the source of back pain. So especially the ligaments are the cause of the back pain. So when you see the posterior longitudinal ligaments, that prevents disc herniation. When you see on the second image, you can see that the disc herniation impinging on the nerve roots. This usually the disc herniations occur on the posterior lateral aspect of the annulus fibrosus because that's the most weakest part of the annulus fibrosus. As you see on the first image, the posterior longitudinal ligaments cover most of it, but it is deficient on the posterior lateral aspect. Because of that reasons, usually the disc herniation. This is one of the anatomical correlates that you should know because the posterior longitudinal ligament doesn't cover the whole posterior part of the vertebral disc, so it's deficient on the posterior lateral aspect. That's why most of the discs are either foraminal, paracentral, or extra foraminal because that's the weakest part of the annulus fibrosus. So when you see the disc composed of three things. This is the nucleus pulposus, the central part. Then we have the annulus fibrosus and the CEP, which is the cartilaginous endoplates. These are the three most important components of the disc. So as you see, the disc is very important for equally distributing the weight from the upper vertebrae to down vertebrae. So if there is any abnormality on the disc, this might result in unequal distributions of the weight to the inferior vertebra. That might lead to excessive stress on the annulus fibrosus, as well as on the bones. That results in either tear or strains of the ligament that might result in the back pain. So when we see the physiologic components of the disc, especially the nucleus pulposus, which is the gelatinous part of the disc, it consists of water, mainly 77%, and it consists of protoglycans. These are highly negative aggregates. So it has high negative charge, so it draws water. So that's why its water content is much higher in nucleus pulposus. When we see the annulus fibrosis, it's multiple layers, consists of 23 to 25 lamellae. These are mainly collagen type 1 fibers. So their tensile strength is much higher than that of the nucleus pulposus. So they tend to prevent any herniations of the nucleus pulposus. So the cartilaginous plates also have the same components, but more of collagens and other. So these are the three components of the disc. It's very important to note this one because all pathophysiologic mechanisms that are associated with disc degeneration occur mainly at the cartilaginous plates as well as the nucleus pulposus, which are the first areas of degeneration. So nucleus pulposus, its embryologic origin is from that of notochord. It is a remnant of notochord, and it's one of the largest avascular structure found in our body. So it's relatively avascular. So it's one blood supply comes from diffusion. So diffusion from the cartilaginous plates. So normally, so there are diffusions of oxygen, nutrients, and supplies from the blood, the capillaries that are found around the cartilaginous endosomal and also the vertebral blood supply, which goes around the two sides of the vertebra. So as age increases, this cartilaginous plate will undergo ossification, which makes the nucleus pulposus relatively hypoxic areas. That's why normally finding a black disc or a dehydrated disc is not a disease by itself. It is usually due to an aging process. So finding a black disc is not related with the pathology. So as an individual age increases, the cartilaginous plate will undergo ossification that will prevent blood supply going to the central disc that causes the disc to become hypoxic and relatively dehydrated. That's why you see the black disc continuing aging for all this. So it's a normal aging process. So when we say intervertebral disc degeneration or disease, degenerative disease, this aging process is fastened because of the imbalance between the catabolic and the anabolic repairing mechanisms of the disc. So in some individuals, this aging process will be fastened and it might be manifest with back pain. That's why we call it it's a degenerative disc disease. So having a black disc is not related. So knowing this is very important. So this is more pictorial representation showing the diffusions of fluid and oxygen. So normally during daytime, because of the weight bearing mechanism, the water content of the discs usually is low because of the pressure effect. But during nighttime, this nucleus pulposus, because of the high aggregants and negative charge, the water content will increase. That's why individuals, their individual height might vary during daytime and nighttime because, as you know, most of your heights comes from your vertebrae, and most of the heights comes from the height of the nucleus pulposus. So usually the nucleus pulposus expands during nighttime, it will regenerate, and the oxygen and other metabolic nutrients usually will be repaired during nighttime. So as we discussed earlier, so there is always an imbalance between this catabolic and anabolic process in the disc region. So this imbalance is what we call degeneration. Especially there are like matrix metalloproteinases. These are one of the most common causes that cause collagen degradation and the degradations of the protoglycans. So this will result in loss of hydrostatic pressure, so that will result in a decrease in height, and degradations of the collagens will result in loss of structural integrity. all this combined with increased inflammatory conditions like increased interleukin-1, interleukin-6, tumor necrosis factor, all this results in pain because usually in degenerative disc disease, they will have this excessive catabolic state than the metabolic one. That is one of the inflammatory pathophysiology. So when we see the nerve anatomy, so we have the spinal cord. From the spinal cord, we have the spinal roots. There are two roots. One is the recurrent nerve. The recurrent nerve is responsible for supplying the discs and the ventral parts of the deer. So whenever patients having annular tear, so the nociceptive receptor is coming from the recurrent nerve. So the other nerve is from the posterior rami. This is a medial branch that supplies the facets. So the facet is usually one of the common causes of pain, and facet pain is also different from that of the annular. So we have the medial branch which supply the facet, which is the one of the cause for the pain, and we have the recurrent branch which supply the disc and the ventral dura, which usually passes the sensation during the annular tear or disc herniation. So these are the two important. One anatomic consideration to know is this medial branch. So when you see it on this picture, so the medial branch supplies the upper facet as well as the lower facet. So one of the current medication that's the management option is to give facet block or facet injection. So if a patient has a pain originating from one of the vertebrae or one of the facet, it's usually customary to give the upper and the lower facet to block the whole thing because the single nerve will supply the upper and the lower facet. So this is one unique thing in the medial branch. So giving one facet injection alone in one of the facet might not relieve the pain. So all this will result in degenerative process. So this is the normal, and on the right upper corner, you see that the vertebrae, the disc, and the ligament and flavum, what we call the yellow ligaments. So ultimately, when there is a disc dehydration, there will be loss of height. This loss of height will result in unequal distributions of the weight. That results in significant stress on the annulus fibrosus. And so as a result, there might be tear of the annulus fibrosus, which the patient might present with back pain. Unequal distribution of the weight also will impinge a significant amount of weight distribution on the pedicles as well as on the ligament and flavum. So like any muscular structures, if a ligament is subjected to significant amount of force, it undergoes hypertrophy. So on the left corner, you see that, so because of that fact, the facet will undergo hypertrophy. This is what you see on the both right and left lateral. The facets undergo hypertrophy. The ligament and flavum will also undergo hypertrophy. And there will be this ultimate process will result in a spinal canal stenosis. So ultimately, patient might present with back pain, with radiculopathy, as well as neurogenic claudication. Usually, neurogenic claudication, we'll discuss it later. There's the final stage of degenerative disease. It tells you that the canal has significantly stenosed because of hypertrophied facet, hypertrophied ligament, and that disc herniation. So on the lower corner, on the left lower corner, you see the imaging, T2 axial image. You can see that the ligaments are initially small. These are a normal. On B, you see a normal axial T2 weighted image. You see the ligaments are like, the ligament and flavums are small. The theca is well open. But on the C, you can see that the ligament and flavum has undergone hypertrophy that results in canal stenosis. Usually this finding, you'll see it on the late stage of degeneration. So this is all about the anatomy and the etiology. When it comes to doing history and physical examinations in patient, always when you find patient with back pain, so two important questions should be answered. The first one is there any serious systemic disease that causes this pain? So this is very important. If patient has history of malignancy, history of trauma, history of like infections, recurrent UTI, and so we have to ask this question: is there any serious systemic disease that might result in the current pain? The second one is there any neurologic compromise that might require surgical evaluation of this patient? This is very important. So any attempt on taking history and doing the physical examination, you have to answer these questions. Once you have answered these questions, then the next thing will be to classify the patient having spine-specific causes or non-spine-specific causes. If a patient has spine-specific causes, then is it an axial back pain or is there radiculopathy? So you can classify the patient as only having back pain, that's axial back pain. If the patient has pain radiating to the legs, that's radiculopathy. And if the patient has neurogenic claudication. This is very important because the first two, most of the time, like 90% of the time, the treatment is medical treatment. If a patient comes with neurogenic claudication, that's, as we discussed earlier, these are the late stages of degeneration where there is facet hypertrophy, there is ligamentum hypertrophy, ultimately resulting in severe stenosis. Most of the time, they don't respond for medical treatment. So the patient either have to go neurosurgical evaluation, possible decompression. So answering these two questions and classifying the patient into these categories is very important. So when you take history or physical examination, so red flags should be always asked in patients with back. So when you see the red flags, so whether the patient is having cancer or infections is very important conditions. And usually when you see red flags like age greater than 50 and younger age less than 20. When we say age greater than 15, usually we are saying that a new onset of back pain in a patient which is older than 15 years, which has never been there, is also a red flag because usually most of the time, as we discussed, it might be a sign of serious conditions like metastasis and other things. So a new onset of back pain in the age of greater than 50 years should be thoroughly seen or investigated. Younger patients usually they don't usually have disc problems, but when a young patient complains back pain, so it might be a serious condition, might be as small as benign condition like osteoblastoma, or it might be serious condition, including tumors and other things. So younger age and age greater than 15 with new onset of type of back pain. So if a patient has a history of malignancy, we have discussed earlier, unexplained weight loss, immunosuppression like seroreactive or VI patients, patient who are taking immunosuppressive drugs, complaining back pains is a red flag. And patients, especially with recurrent UTI, who have like a structural problem on the urinary tract system, usually they tend to have recurrent UTI. Through the basal plexus, patients might develop osteomyelitis and pyogenic infections of the disc with discitis. So a patient, not single time UTI, but those with structural abnormality with recurrent UTI, complaining back pain should be sought and investigated thoroughly. And those patients with traumas it's a significant history of trauma. They should be investigated thoroughly. And those who have prolonged use of steroids, especially subjected to have osteoporosis as well as infections. So the other most important thing to ask on red flags are the presence of cardiac syndrome or severe neurologic compromise. If a patient with back pain comes with tingling numbness sensation over the lower legs, saddle anesthesia, any bowel and bladder incontinence, and if a patient presented with progressive types of weakness, these are said to be red flag. Mentioning this red flag here is very important because a red flag, if a patient has one of these red flags, so they should be sought or investigated thoroughly. But patient without red flags and they are like presenting for a few days of symptoms, they don't need further investigation. But red flag symptoms, if there are red flag symptoms, patient should need an investing imaging modality, including MRI or other types of imaging. So one of the things that usually we omit and we tend to neglect is the yellow flag. So most of the back pain patients are associated with the psychosocial problem. So they don't present you with only back pain, but they have the whole psychosocial, environmental factors, stress, relationship, mental health problem. And usually when they came, they are like devastated because they have severe disabling thing that they think that they cannot be normal. So these yellow flags usually tends to cover the psychosocial components of the back pain, and it's very important according to my little experience. So if you treat only the pain, usually the patient will be there for a long time. So you have to give some kind of cognitive behavioral therapy, link them with psychologists or psychiatrists to have this, because usually they have this psychosocial problem, and addressing that is very important. So when it comes to the classifications, low back pain can be classified into different variety depending on the causes, or it might be etiology, it might be severity. So the commonest classification is based on duration, and this is very important because classifying the patient's back pain into acute, subacute, and chronic is very important, because acute and subacute pains usually, most of the time, they respond by themselves, even though they are not treated, if the patient doesn't have any red flag. So most of the time they are like self-resolving symptoms, but those patients having a chronic or persistent types of back pains are the one which needs follow-up and thorough investigations and treatment. So when we say acute low back pain, this is a back pain of patient having less than 4 weeks. If patient comes with symptoms of 4 weeks, then this is an acute. Between 4 weeks to 3 months, it's subacute, and chronic is more than 3 months. Based on anatomical side, it might be axial, that is back pain, then radiating type. It might be radiating type, this is radicular lower back pain, usually radiating to the buttock, the single legs or bilateral legs. So it might be, depending on severity, it might be classified into mild, moderate, severe. There are different classifications of severity of pain using Roland Morris or visual analog scale and other things, where you classify them based on those. So there are different classifications, but for simplicity purpose and for management purpose, personally, I prefer to classify the patient with acute, subacute, and chronic one. But classifying this as acute, subacute, and chronic, it doesn't tell you the etiology. So it only classifies the fact that the patient is going to have improvement or not improvement. Generally, chronic tends to persist. Those with acute and subacute, if they are treated well, they resolve by themselves. 90% of them, they resolve by themselves. So categorizing is very important in decision making, as we discussed earlier. Acute, subacute, they resolve most of the time by themselves. Chronic, they tend to persist. If it's chronic, you need to do an appropriate diagnostic workup with lining of effective management strategy should be lined up. So classifying into these different groups is important for your decision-making purpose. So when we see, depending on symptoms, patient might present with axial back pain. This is a pain restricted to the lower back, that is between the costal margin to the gluteal fold. Most of the causes might be discogenic or mechanical in nature. That means it might be ligament tear or strain, or it might be the cause of the pain might be discs, and usually they don't involve the nerve root. Sometimes they might be related with disc herniation. It might proceed disc herniation, but most of the time the roots are not involved. So patient might come with only an axial back pain. The other presentation might be radicular pain. This is the pain radiating to the buttocks, so the legs. So usually when patients are in radicular pain, the pain is worse during sitting, because when you sit, the pressure on the spine is very high. So when a patient, for example, lies in supine position or prone position, the intradiscal pressure is around 90 kilopascal, but when we sit, it's around 593. That pressure will be transmitted to the disc, ultimately to the nerve root. So patients having radicular pain to the legs, usually they have worsening during sitting. Sometimes it improves with standing, but it depends on the patient's clinical condition and the stages of the disc herniation. So radicular pain, sometimes they might worsen by cough, valsalva, or sneezing because of the increased intradiscal pressure. So they might be impingement of the nerve root. Sometimes patient might say that pain is not worsened during ablation, but as I've told you earlier, this is depending on the stage of the disc herniation. Patient, for example, they might present with severe spinal canal stenosis as well as foraminal stenosis. So during this case, this might not be true. So patient might have worsening while walking, even sitting. But if it's a pure disc, recent onset, then patient might present with such kind of presentation. The other thing we fear, which is present in 1 to 10% of individuals, is the Ethiopian syndrome. This is a surgical emergency, so always I advise my students and my fellow residents to look into these symptoms, because if a patient comes with a Ethiopian syndrome with disc herniation, they should be treated as an emergency, so within 24 hours, because usually after 24 hours or more, it's very difficult to reverse the bladder and bowel complaints of this patient. So usually patients present with bilateral leg pain. If it's like the lower nerve roots, the pain might be asymmetrical, worse on one side, the weakness on the lower limbs, depending on the nerve root that's impinged. Patient might present with foot drop or the other thing, depending on which nerve is involved. And they will have bladder and bowel symptoms like urinary retentions. Initially, they will have urgency with urgent incontinence, but later they might present with retention also, and especially they will have saddle anesthesia. They will have saddle anesthesia around the S2S3 area, that's around the perianal area. So looking for these symptoms is very important, especially those present with acute severe radiculopathy. So looking for such, not only asking, doing a proper examination to look for the Ethiopian syndrome is very important, because sometimes you might miss this important finding and miss the opportunity to treat the patient. So Ethiopian syndrome might be one of the presentation. So red flag against, these are very important, should be at the tip of your tongues. So a patient with low back pain presented with this history of red flag, they should be investigated thoroughly, because they usually have severe form of disease behind their symptoms. So these are more detailed history of more detailed red flags, so you can read on this. So when it comes to the topics of the disc herniation, so most of the disc herniations, be it in cervical or lumbar, they occur on the most mobile part of the spine. For example, when you see on the lumbar, 90% of the disc herniation occur between L4, L5, and L5S1. When you see on upper cervical, the most disc herniation occur in 4, 5, C5, C6 areas. This because they are formed for wear and tear, and because of that fact, the most disc herniation occur on the most mobile parts of the spine segments. So when a patient comes with disc herniation, these are the commonest, as you see, almost 90% of the disc herniation occur between L4-5 and L5S1 areas. And usually, if you have L3, L4 disc, usually the impinged roots are the lower one. If you have, for example, L3, L4 disc, the L4 is going to be the one which is impinged. Because I have told you that the most deficient part of the disc, the weak part of the annulus fibrosus is the paracentral zones. So the paracentral zones are the exiting roots are the one which is going to be affected. If the disc herniation is central, then the next root will be, for example, in L3, L4, if it's central disc, the L3 will be affected. If it's L3, L4, it's paracentral roots, paracentral disc herniation, the exiting root, that is L4. So most of the disc herniation occurs in the paracentral root, and the lower roots are going to be affected. So it depends. For example, L3, L4 disc, if the nerve that's going to be involved is L4, so when you do physical examination, so the knee jerk, when you see the reflex that's going to be diminished is the knee jerk, the knee reflex, and the motor weakness is the quadriceps. So the quadriceps femur is that the knee extension will be weak. So decreased sensation over the medial malleolus, the medial foot, we will show in pain distribution is over the anterior. When you see the L4-5, the L5 foot are going to be affected. And the main motor weakness is the tibialis anterior and extensor hallucis longus. So patient will have weakness of plantar flexion. And especially if you see the L5 root, the extensor hallucis longus is going to be, so patient will have weakness of the extensor hallucis longus. So they don't extend the big toe. I will show you a picture later. So S1 roots, the same, the ankle jack will be different, depressed. Patient will have gastrocnemius weakness, so they have difficulty of the gastrocnemius. So patient cannot footwork, toe work. So extensions of the plantar extension will be weak. So the dermatomal distribution is. So when you see physical, when you do physical examination, it starts with inspection. Sometimes patient, they might tell what you have, what they have whenever they enter to your outpatient clinic. Sometimes the patient will bend on one side. This is what we call the lateral racer syndrome. The patient is trying to open the foramen on the contralateral side. For example, if a patient has L4-5 disc on the right side, impinging on the right L4-5 nerve roots, then the patient will try to be bent on the left side so that it will try to open the foramen on the right side. So it tells you something. So usually when they come in, it tells you that the patient has this lateral racer syndrome. So patient position also tells you something when they even get into your OPD. So each nerve root has dermatome and myotome. So obviously most of you knows about this myotome and dermatome. For example, if a patient has L3 radiculopathy, so this is the iliopsoas muscle. So patient will have flexion weakness of the iliopsoas. So hip adduction weakness will be there, knee extension weakness because some of the fibers will contribute to the gastrocnemius, and patient will have dermatomal pain over the anteromedial thigh. I think it's better. So for example, this is the first image you see that hip flexion is by L to L3. So if a patient has abnormality or disc on the L to L3, they will have weakness of the hip flexion. And hip extension is by gastrocnemius muscle, or sorry, gastrocnemius, hamstring muscle, and hamstring muscles are supplied by L5S1. So hip flexion by L1, L to L3, hip extension by L5S1. So when you see on the next image, knee extension and knee flexion, knee extension is by quadriceps muscle, that's L3, L4. Any patient who has disc on L3, L4 will have weakness of the L3, L4 dermatome. It might, depending on which nerve roots are involved, or knee flexion is by hamstring, which is L5S1. So when you go to the lower nerve roots like L4, L5, L4, L5, plantar dorsiflexion is by L4, L5, and plantar extension is by S1. Inversion, usually they are not much important, but important to know inversion is by L4, L5, inversion is by L5, S1. So this is the myotome, and this is how you examine the patient. So you grade the power depending on the 5, 4, 3, depending on the Frankel grading of the motor system. So specifically, if this is what we are discussing earlier, L5 extension. So this extensor hallucis longus, specifically the L5 roots, will supply the extension. This is the big toe extension. If a patient has L5 impingement, then you will have weakness of this. So it's usually seen in L5 radiculopathy. So S1 supplies the gastrocnemius, and the dermatomal supply is to the lateral part of the calf, the part of the foot. Usually patient will have ankle plantar flexion weakness, and they will have diminished ankle reflexes, and the dermatomal pain is on the posterior part of the calf and the lateral. So this is the dermatomal representation. So you can see that for each nerve root. So you can see that this is a repetition. You can see it later in. So this is also the same, the dermatomal picture representation. So whenever you do examination, so L4-5 disc L4 impingement, and you see the dermatomal distributions of L4, and you examine the specific motor weakness on L4. The same happens to L5S1 and the rest of the disc. So dermatomal. Cardiac syndrome, usually they will have saddle anesthesia, decreased pain and sensation over the buttock perianal area with decreased anal tone because of the affections of the pudendal nerve. And they have also pain, absence of pain around the anus. That's what we call a saddle anesthesia. So sometimes we do provocative test, whether to test the lower back pain is associated with some significant disc herniation or which specific part of the spine is involved. For example, one of the tests that we do is straight leg raising test, or we call it the Lisago sign. This usually tells there is a tension on the L4-5 and S1 nerve root. So the lower nerve roots stretching during this provocative test. If there's an abnormality on this L4, L5, S1 root, patient will have a positive straight leg raising test or Lisago sign. This technique is done by raising while the knee is extended, you raise the leg to the level of 40 degrees, sometimes to 60 degrees. So during that time, if a patient has significant disc on the above mentioned areas, patient will have pain radiating to the legs and the buttocks because of impingement of the nerve root, because of heart stretch. And this is what we call the positive SLR or positive Lisago sign. There is a test called crossed SLR. So if a patient comes with pain, for example, on the left side with radiculopathy, then you try to raise the right one. So if the patient develops the same kind of pain on the left leg, it's called crossed SLR. When we see the SLR and the crossed SLR test, the SLR test is said to be more sensitive. It tells you that there is an impingement on the but the specificity is low. But on the crossed SLR, if both SLR and crossed SLR is positive, it tells you that the patient might have significant disc that might require surgical indications of that patient. So having a crossed SLR positivity tells you high specificity of the disease pattern. So always try, if you find a positive SLR test, try to elicit the crossed SLR test. Then that tells you the patient might have surgical disease. That usually this occurs because of impingement of a large medially oriented disc on the affected nerve root. The other is the femoral nerve sheath test or Wassermann test, Wassermann sign. This is for the upper nerve roots between L2 and L3. The SLR is for the lower L4, L5, and S1. This femoral nerve sheath test or Wassermann test it's performed under prone position, as you see, also it's depicted on the lower picture. So you try to raise the thigh with a flexor. Then patient will feel pain around the thigh, the anterior thigh area. Patients having pain around the L3 dermatome or L2 dermatome, we call it a positive femoral nerve stress test. This is what we call the Wassermann sign. So when it comes to the investigations, usually, depending on the patient presentation, patient might have acute back pain or chronic or subacute one. Usually we don't tend to do investigation, but these are the commonest blood workup we do. We have complete blood count if you suspect any kind of infection, ASR for the same, like if we suspect TB spondylitis or chronic infections or chronic inflammatory condition, we try to do ASR, C-reactive protein for the same inflammatory or infectious conditions. If a patient has also, if you suspect some reactive arthritis like ankylosing spondylitis, we do HLA B27. And sometimes, as a trend, most of us do also vitamin D level. Yeah, vitamin D level also associated with back pain. So there's pathophysiology concerning the vitamin D level is one of the causes for the having low vitamin D level might result in back pain. So it's one of the investigations that commonly done in terms of blood workup. So when it comes to imaging, one thing I should mention is not most of the patients with acute back pain, they don't need any kind of investigation. The initial part is to reassure them, maybe give them like simple, unless otherwise they don't have red flag. If it's recent onset, most of the time, 90% of them, they respond very well. No red flag, no weakness, nothing, no worries, no worrisome, then you don't need any kind of investigation unless otherwise there is other metabolic or inflammatory condition that they are suspect. But those with chronic, subacute and chronic, they might warrant you to have like some kind of imaging. Among the imaging we do is a simple radiograph. The recommended views are AP, lateral. Usually we do it if, for example, patients need surgery. Sometimes they might have this sacralized and lumbarized, which will affect your surgical localization. So you might need to have an X-ray. The others are like if you're suspecting like rheumatoid ankylosing spondylitis and others, so you might include also the pelvic to see the SIJ, the sacroiliac joints, whether their back pain is associated with those inflammatory conditions. But usually the amount of information you get from an X-ray is limited. So usually they are not the common types of investigation that we do. Sometimes we do also optional views. These are flexion extension view if we suspect any stability, because some of the discs that you see, especially if you find higher disc like L4, L5 disc, usually they tend to occur if there is an associated instability. So usually having flexion extension X-ray, especially if you're going to do surgery, is very important because sometimes patient might also need stabilization, TLIF and other procedures. So flexion extension X-ray might be another option. So these are a simple X-ray. So on the first picture, this is a normal picture. What you see is P stands for the pedicle, NF stands for the neural foraminal, S stands for the superior articular facet, I stands for the inferior articular facet. This is F is the facet joint. Usually this facet joint undergo hypertrophy is that whenever there is an hypertrophy, there is foraminal stenosis. So usually this when the joints hypertrophy, it compromises the nerves. That's why facet joints, facet hypertrophy are one of the cause for radicular pain. So on X-ray, you can see that the disc heights are well maintained. The cartilaginous in the plates are very important, whether it's ossified or not. On the next picture, you can see that there is like listhesis, especially on this L4-5 area, this significant listhesis. When you see the cartilaginous in the plates, they are also more of ossified. It tells you in the disc height is reduced. So you can have some kind of information on the on the X-ray. So usually you need to know your anatomy to interpret your X-ray. If you know your anatomy well, then you can describe most of the pathologies under X-ray. But usually it doesn't correlate with the patient. So if a patient has significant degenerative disease on X-ray, it's better to have MRI to see the details of the ligament and the disc structures. Sometimes it's very important because sometimes disc might be calcified that you might not see it on MRI. That is difficult. That's a completely different approach when you do surgery on this patient. So that might give you an additional information. So CT myelogram, usually we don't do it here, but for those patients who have like, you cannot do MRI because of the implants, the pacemakers, or what we call the hearing aid implants. You cannot do MRI because of the magnetic nature that will disrupt the functions of this sensitive instrument. CT myelogram might be the best for those patients because the sensitivity is as good as MRI, which is like 90% accurate on diagnosing the discs. Sometimes it might be difficult to see it if the disc herniation is extraforaminal and foraminal. It might not tell you something, but for those patients who have like this pacemaker and CT myelogram might be a good option. So you can see that it looks like an MRI. So the CT myelogram of the patient, you can see the details of the nervous structure. If there's a disc herniation, you can see it very clearly. But if the disc herniations are foraminal and extraforaminal, it might be difficult to see it on CT myelogram. So the standard of choice is MRI without gadolinium. It is highly sensitive and highly specific. It's very helpful for your preoperative planning. And usually we don't do MRI for all patients with low back pain. This is one of the most difficult things we're facing. So patient come, somebody will order MRI. Obviously, they will find something because above the age of 13 years. So the probability of having some kind of disc anomalies or disc problem is 24%. So this will result in some kind of psychosocial or psychological problem for the patient. So you don't do MRI for every patient for whom is complaining low back pain. So the indication for obtaining an MRI is if a patient has red flag, or if the patient has pain which is lasts more than 1 month and not responding for any kind of non-operative management. And if the patient has one of the red flags, then it's mandatory to have a marker without gadolinium. Sometimes you might need to have this contrast. So contrast is important if you suspect any kind of infections like TB or pyogenic abscess, or sometimes if you suspect tumors also, we can do with MRI with contrast. So this is the normal MRI of the disc, the normal lumbosacral MRI, and the normal disc MRI. You can see that there is T2 and T1, T2 on the right corner, T1 on the left, and T1 is contrast on the right side. So on T2, you can see that there is a very bright disc, nucleus pulposus, with the dark one is the annulus fibrosus. And you can see that the signal intensity is the same as the CSF. So whenever there is disc dehydration, it tends to become darker and darker. That tells you that there is a disc dehydration. As age increases, it's a normal aging process. This doesn't mean that the patient is having a disease pathology. So it might be a normal aging process. But sometimes the patient might be like very fast associated with the pain. That's what we call a degenerative disc disease. So usually the disc is hyperintense, white in central on T2 and dark on the because that to see the annulus fibrosus. So this is a normal disc. You can see on the height of the disc, on the intensity of the nucleus pulposus, whether there is a clear demarcation between the annulus fibrosus and the disc. So usually when the disc dehydrates or degenerates, this demarcation between dark and the white nucleus pulposus it's become less conspicuous. So usually, ultimately, the disc totally become dark. So depending on the disc degeneration stage, then that will happen. So this is a normal sagittal MRI. So it's very important. The take-home message from this is it's a very common disease. And low back pain is one of the commonest outpatients. So everybody should know to read the basics of the lumbar spine. So especially to know whether the patient has some surgical disease or not. Knowing the basic anatomy is very important. So this is a T2 image. It shows you that the disc, the height is maintained, the decentral disc is wide. So as the aging process continues. So this is sagittal imaging, T2, showing you the facets. It's very important, and showing you the foraminas and the roots. So usually there's like right root, left root, and usually the disc herniation occurs around these paracentral zones where it impinges on the nerve foraminas and the nerve roots. So knowing this anatomy is very important. So you have to know whether both axial and sagittal image to interpret the orientations of the disc herniation and also the level and the degree of the disc herniation. This is the sagittal T2 image showing you the nerve foraminas. These are like a teardrop. So whenever there is a disc herniation, the teardrop, the lower part will be obliterated. So the foraminas become more compromised and compromised. So sagittal imaging also is very important to grade the foraminal stenosis. Is usually graded based on the sagittal image. So knowing this is also very important. So there is a grading of the disc dehydration. So you can read about this. There is also the same grading of the foraminal stenosis based on the axial and the sagittal image. You can read. So there are different terminologies. These are like disc bulge, annular tear. These are usually diffuse types of. So when there is a focal herniation, we can classify the patients having either protrusion, extrusion, or extrusion with sequestration. Protrusion means the disc is significantly protruded and it's more than 180 degrees. Extrusion means there is a neck, but there is a neck which is connected with the disc. When we say extrusion with sequestration, there is a complete separation of the disc material from the annulus fibrosus. So there are different terminologies that you have to know this one. So when we see the disc herniation, it might be central, as you see it on the first right corner, or it might be paracentral, or it might be foraminal or extraforaminal. So this is very important for those with posterior part of disc herniation. On sagittal image, these are like extruded disc. The migration might be upward and downward. And the patient presentation might vary depending on the migration of the disc, because usually the nerve roots is found under the pedicle. Those patients who have an upward migrating disc become more symptomatic than a downward migrating disc. So this also has some kind of clinical significance. So this is, as you see it on MRI, sagittal T2, we can see that the lower part of the disc is black and there is herniation, especially the paracentral disc herniation, and there is significant stenosis of the foramina as well as compromisations of the spinal canal. So this is what we call typical patients which present with severe radiculopathy. Patient might present also cardiac syndrome if the patient is an acute disc herniation. So this is important picture to look. So this is the same thing we have seen. So usually, as you see on this picture, the nerve roots are passing under the pedicle. So patient might present with disc herniation which migrate downward or it migrate upward. Usually migrating upward disc will have the exiting root of the upper one. If it's migrating downward, it will find the lower nerve root, the lower exiting nerve root. So usually upper migrating disc roots, upper migrating disc, usually they become symptomatic less early. So when we see the disc, if it's central disc, then it's not the exiting root that's going to be compressed, but it's a lower root. So L45 disc, if you find L45 disc, central type of disc, then the impinged nerve will be the L5 one, not L4. If it is paracentral disc, then L4 will be the one which is going to be affected. This is what topic we were discussing earlier. So I'm almost done. So the last is spinal stenosis. Usually, as we discussed earlier, neurogenic claudication is one of the presentation patients with neurogenic claudication is one of the presentation. Spinal stenosis. Spinal canal stenosis is the last stage of degeneration, because usually this occurs because of the hypertrophied facet, hypertrophied ligamentum flavum, hypertrophied laminas, herniated disc. All these things will result in significant canal stenosis, and patient will present with a neurogenic claudication. Such patients, they tend to worse when they go upstairs. When they go upstairs, they extend. That will result in buckling of the ligamentum flavum. Disc will herniate, and patient cannot walk upstairs or walk like hills. So usually they are okay when they go. When they go like downstairs, so it will buckle. So patient will present with a kind of neurogenic claudication. So they will have significant stenosis of the canal during extension position. So when an individual tries to go up, yeah, I'm right. When they're trying to go upstairs, they extend. Because of that, the canal will stenos, and patient will have neurogenic claudication. When they go down, so they'll flex. So that's why usually patient having neurogenic claudication, they will walk for a minute and then they will squat. When they squat, their foramina will open and they will be symptomatically okay. They stand up, walk for a minute, then again they squat to relieve the stenosis. So usually if a patient comes with neurogenic claudication, it's a surgical disease because of this fact that there's like the last steps of the so this is what happens. The normal central canal is like this. But ultimately, with disc herniation, ligamentum flavum, the yellow ligamentum flavum hypertrophy, the facet, all ultimately result in significant canal stenosis. Then patient will present with typical neurogenic claudication. This is patient will walk for a while. They will present with severe numbness and weakness of the lower limb. They will squat for a while and they walk. So sometimes it's very important to differentiate it from vascular claudication because both of them, they might have similar symptoms, but usually vascular claudication, neurogenic claudication, the patient will walk, they will have pain. The pain will not be relieved on a standing basis. So they have to squat or flex for symptoms to go. But in vascular claudication, usually their symptoms usually relieves when they stand also. When they move, when they don't move, the pain will disappear. And then usually it's like a fixed distance for vascular claudication. So they will walk for a fixed distance, then their symptoms starts. But in case of neurogenic claudication, it might vary depending on the severity of the stenosis. But usually in vascular claudication, their pain and numbness stop even when they stand, but not in neurogenic claudication. So it's important to differentiate the two. Always in patients with neurogenic claudication, you have to look for the pulses. Usually they have normal pulse, normal hot leg, and they don't have any abnormality in temperature of their skin. And the pulse is very palpable on the dorsal spadius but in case of the vascular claudication, they have mottled skin, cold extremities, and the pulse is difficult to appreciate. So ultimately, this is so patient with back pain, they might have axial or musculoskeletal pain, they might have radicular pain, they might have systemic disease, or they might have neurogenic claudication. So this is the algorithm that you might need to select. So treatment, it depends. For most of the patients, we have bed rest. Usually, it depends. So there are like different kinds of recommendations. Most of them, they are not backed up with randomized control trial or male-centric trials. So they are like, sometimes they are like expert opinion. Sometimes their recommendation is not that much strong. But one works for one individual and one it doesn't work. Usually you have to tailor the treatment based on the patient's response. It's usually depending on the patient's response. So usually for acute back pain, usually bed rest is recommended. Not more than 4 days. Some literature says 4 days is the maximum that you should advise to get bed rest. And during this time, you advise the patient not to do many activities that increase the intradiscal pressures, such as sitting, bending, lifting, and other things. Or sometimes traction, spine manipulation. They don't have strong recommendation, but they are like expert opinions here. So this is what you advise patients. So most of the exercise are this pelvic tilt exercise, which increases the pelvic floor muscles and which also strengthens all things up. When you advise patients, the biomechanics start from this one. So patient having prone position, the intradiscal pressure is around 91 kilopascal. So if a patient bends like 90 degree, the disc pressure is 1,324 kilopascal. You can imagine that adding 1 kilo will triple the amount of pressure on the back. So you can advise them not to pick heavy object, not to bend and other. This is because of this is the in vivo research done. So all advice are based on this paper. So lumbar bracing, they have also sometimes they are like, okay, sometimes they work for patients, sometimes they are not recommended, but for recommendation purpose, it's not recommended to put patients for longer period on lumbar brace. That might result in weakness of the lower because it tries to bear weight. So it weakens the lower muscles, lower lumbar muscles. So it's not advised to give patient for longer period of lumbar braces, so not more than 20 days. So pharmacotherapy, this is, so among the drugs, we have the acetaminophen or Panadol or paracetamol, and the NSAIDs are the one which has strong recommendation, at least level B recommendation, and they should be given for a period of 4 to 6 weeks. My recommendation is for only those patients with chronic back pain. Here, my recommendation. But it's very different for acute, very different for radiculopathy and other things. So it depends on what type of disease you have, whether you have an acute, subacute. It varies whether you have an axial back pain, radiculopathy, or neurogenic claudication. So it might be non-steroidal anti-inflammatory drugs are said to be the one with the recommendation. So these are the recommendation we have for example, psychosocial therapy. It's very important for those with chronic back pain, including multidisciplinary approach. Exercise, usually these are like different kind of exercise. The exercise usually that's recommended are lower back muscle strengthening exercise. There are specific exercises that are done by physiotherapists and also chiropractors, and so they are strongly recommended for a patient with lower back pain. So treat them initially to relieve their pains. After the pain, then they have to undergo this physical therapy. It's a strong recommendation. When you see the physical modalities we have, these are the general or what we call the exercises. So this transcutaneous nerve stimulation, epidermal tractions, ultrasounds, these are like the marginally supported documents, marginal. Whereas electrical stimulation, shortwave diathery, lower level lasers, these are some of the new we have. These are like also cannot determine the recommendation. You can, it's an eye, so you can read about. So usually for patients with back pain, NSAID, Panadol, Amstel, for Panadol or NSAIDs, then for those with chronic back pain, multidisciplinary team approach and physical exercise are said to be the one which the patient usually responds very well. For the rest, either it's an expert opinion or there is no strong recommendation for those matters. The last will be indication for surgeries. So indication for surgery are mainly two. These are patients with having cardiac syndrome, weakness, and those patients who fail to respond after 8 weeks of conservative management. So usually the conservative management are limited, not limited for days. They should be continued for at least a minimum of 4 to 6 weeks. Some says 8 weeks of treatment. So we said patient do not respond if the patient has taken the medication properly, has finished everything. So then that's what we say patient has failed the conservative management. So it depends on also the local guideline. For example, when you go to US, so currently they have adopted spinal epidural injection as one of their management modality. Patient has to go to the spinal injection before they decided to go on surgery. So it depends from one country to other country. But failure to respond with conservative management, dense motor deficit, progressive deficit, and cardiac syndrome are said to be the indication for surgery. So there are different kinds of surgery. We classify them into open and endoscopic. Endoscopic, usually the recent one, usually don't practice it. We practice it here actually. We started practicing endoscopic surgery. We have minimal invasive using tubular retractors, or it might be open. Unfortunately for us, most of our patients, they came late with severe spinal stenosis, and they are not like usual candidates for minimal invasive surgery. So most of them, they have significant canal stenosis. You have to open and decompress them, but there are patients who are very eligible for minimal invasive surgeries like microdiscectomy and that. So this is all I have. Thank you for your utmost attention. If there are any question, I would be glad to answer.
Thank you, Dr. KIBRUYISFAW. That was a very interesting presentation. I think lower back pain is one of the most commonly encountered ailments in both patients as well as physicians, especially in primary health care. So you've managed to present it in a very comprehensive and applicable manner. So thank you for that once again. So having said that, we'll directly proceed to the Q&A. So the first question is, currently there are places where they are boldly advocating some kind of stretching approach to realign the disc problem. Is there any benefit from such approach?
It's a very good question. So, as I have described it earlier, so one of the treatment is spine manipulation. So one of the treatment options is spine manipulation, and one of the thing is traction. So the rationale behind this is, so if there is a disc bulge while you try to do a traction, so you stretch the posterior longitudinal ligaments so that you try to push the disc back into the place. So it's theoretically, when you see it, it's theoretically, but it's not backed with scientific data. So currently there is no strong randomized control trial, multicentric trial, which advocates a spine manipulation or traction should be recommended for patients with low back pain or disc bulges. But there are like some papers, like hospital-based studies, saying that might recommend this traction. So, but when you do it, it should be done under trained individuals, and the patient should have specific indication, not for those patients with extruded disc, which needs surgical intervention. Some patients might worsen with this traction in that.
Thank you. The second question reads, what about menopause, BP, and fatigue as a cause of lower back pain?
Yeah. So one of the cause for back pains are variables. One of the things is metabolic cause. This is osteoporosis. So back pain tends to be more common in female after the age of 40 because of the fact that there is hormonal disturbance and osteoporosis risk is very high. So usually women's postmenopausal age tends to have more back pain when compared to those comparable age adult male because of the osteoporosis. So obviously during menopause, the back pain usually worsens. The other is fatigue. The second.
Correct, it's fatigue.
Fatigue is. I didn't get that question, but if it means that if an individual tends to do more strenuous work, like daily laborers and other things, obviously because of the wear and tear effect, they tend to be more affected because they tend to lift heavy objects and other things. That will result in micro injuries of the ligaments. That will disturb also the physiology of the disc dynamics that may cause them to be develop disc. So in identical twins, there are like studies. For example, those two identical twins subjected for different environments that have proven that environmental factors are also responsible for disc degeneration because of that fact. So having such kind of stainless job might for responsible for back pain.
So thank you. The third question reads, one of the most important tools for decision is diagnostic setup, namely the imaging. And this seems a luxury for the majority in the current situation. What should be the role of stakeholders in addressing this problem?
Questions for Udasi and Pioneer if there's any representative from that area. But yeah, I understand. So for example, currently the MRI cost is very high. And so most of the government labor might not even financially fit to have that. But the most important take-home message from our current discussion is most of the patient, they don't require MR. So that's the most important thing that I want to forward for the attendees. It's because those patients who have only red flag, and when we always order MRI, always we have to think one thing. The report or the MRI result, does it change our decision on the management of the patient? Does that patient require surgical intervention or any kind of intervention? We have to always think about that. If there is nothing that we can change, if the patient is well, no weakness, no bladder bowel incontinence, no significant radiculopathy, but only complaining back pain, these patients are not indicated to have an MR. So you just treat them, advise them. If it's chronic, try to do multidisciplinary approach, give them analgesics, advise them very carefully, do an exercise for this patient. If they don't respond, then you order an MRI. But obviously this question is, yeah, it's very difficult, but it's also the issue of the government. So the stakeholders are different. The physicians is one of the stakeholders that you don't have to order MRI for every patient. The second one is, so this investigation modality should be available at every government hospital. Unfortunately, majority of the government hospital, they don't have MRI, despite the commonest of outpatient visits is the lobar. So every one of us should take responsibility from this one. And also, obviously, the private institution also has to take some responsibility on this.
Okay, thank you. The first question reads, what is the role of CT, specifically not CT myelogram, in the evaluation of back pain in non-trauma setting?
It's a very good question. So usually what you'll find, what additional information that you get from a CT is you will have more descriptions of the bony anatomy of the spine. So if you want, for example, do fixation for these patients, let's say a patient have a disc, extraforaminal disc, and you think there's a listhesis, and if you try to do other procedure like fixation and other things, then in that case, CT might help you. First, to know the pedicle size, to know the trajectories of the screws and other things. Usually, if you are going to do surgery, then MRI alone might not be enough. So you need to have CT so that you plan your surgery very well. But usually CTs are, you do CT because we don't have CT myelogram for patients with lower back pain, for those patients who have contraindication for MRI, like those with metal or orthopedics implants. It will tell you, yeah, you need to have a good experience on reporting those. So neuroradiologists might have a very good comparable reading with MRI, but there is always some kind of deficit with CT. But those patients who have contraindication for MRI, you can have some more information than X-ray than the CT, because you do the sagittal reconstruction, you see Jargial. Obviously, it will tell you more than X-ray, but for a disc pathology, MRI is usually better.
Thank you. So the previous question reads, what are the early signs of degeneration on MRI?
So that we have discussed earlier, the black disc, we call it the black disc or disc dehydration. It's said to be the earliest sign. But mind you that this is not a sign of pathology. For example, if an individual is like old, the skin wrinkles, this is not a pathology, this is an aging process. So usually this occurs because of the calcifications of the cartilages in the blood that will prevent the free diffusions of oxygens, nutrients that will result in more degradation and dehydration. So the mere presence of black disc on T2 imaging, it doesn't mean that the patient is pathologic, but that is said to be the earliest signs of degeneration.
Thank you. The sixth question reads, can a disc prolapse, reverse, or heal totally? And if not, is there any need for repeating MRI?
That's also a very good question. So there are reports, patient having like extruded disc, even protrusion. There is a probability that it might resolve spontaneously. There are also, I have read some papers that this might be as high as 20%. So there is a probability that the patient might have resolutions of the disc prolapse or disc herniation. So all it matters is the patient presentation. So it doesn't mean that the patient having disc herniation, that it doesn't mean that all patients need surgery. That's why we usually tend to put some on conservative management first before we embark on surgery. There is potentially there is a possibility that patient might improve by itself. Yeah, so there is a possibility, but usually such kind of things are not advised for those patients with motor symptoms like weakness, patient with cardiac, obviously not cardiac, but significant motor symptoms. And usually you don't wait for those such kind of patients, but yes, there is a possibility that it might resolve by itself.
Yeah, thank you. So the seventh question reads: how long should we continue with anti-pain medication? Should it be continued on a daily basis or as needed?
So as we discussed earlier, the whole purpose of giving NSAID is for two purposes. So one is to decrease pain. The other is usually because of this inflammatory cytokines like interleukin-1, 6, thymorhinopus factor, other matrix metalloproteinase and other thing. There will be not only pain, there will be also nerve swelling. So giving the NSAIDs and this anti-pain for longer time, say to have decrease nerve swelling, that will in turn will give space for the nerves so that patient will have for longer time symptom relief. So the current recommendation for continuing anti-NSAID medication is 4 to 6 weeks. There are also papers which might say as early as 4 weeks. There are also papers which says as early as 8 weeks. So it's 4 to 6 weeks, and it should be given on continuously basis. Always when you order such kind of patients, you have to look for their medical illness, diabetic patients, renal patients. Those are prone to develop like AKI. You have to look for those patients always. You should be watchful on their kidney status and their GFR and other things.
Yeah, thank you. So the next question reads: what is the role of steroid injection for acute lower back pain with radiculopathy, and the role of TCA for chronic lower back pain?
It's a very important, so it's an area of controversy. I cannot say do steroid, not do steroids. So steroids are usually recommended for cervical pains generally, and they are not recommended for lower back pain at all. So there is no strong recommendation to say patient should be on steroid for lower back pain, acute lower back pain. But it's customary that a patient have like lower back pain with radiculopathy, acute one. They might respond for the dexamethasone along with NSAID, but there is no strong recommendation to put as a standard treatment. But for cervical, there are evidence which supports steroid injection. Tricyclic antidepressants, there is a strong recommendation for chronic lower back pain. There are different like duloxetine and the other things are important. Amitriptyline also is, there are like recommendation, especially for those with chronic back pain. It's recommended to give tricyclic antidepressants also. They work by not only decreasing pain, they also act on the pain. If you know the pain theory, then they will desensitize and other. So their effect is multimodal. So tricyclic antidepressants are said to be they are recommended in chronic low.
Thank you. So the last question will be: what is the association of the degree of actual compression and patient's complaints? Because a couple of patients have minimal MRI findings, but worse complaints.
Yeah, it's a good question. So yeah, it depends. So usually we don't treat the MRI, we treat the patients. So that's why sometimes a very good history and physical examination is much better than reading the MRI. Sometimes you do physical examination, you find something when the MRI comes. It's like small disc or it might, but usually the actual symptoms, the patient symptom might vary because usually it's not disc herniation that causes the radiculopathy. It's because of the tear of the ligament flavum. There will be the tear of the annulus fibrosus. There will be interleukin-1, interleukin-6, tumor necrosis factor, metalloproteinases. This all causes inflammatory change around the nerve root that might cause pain. So usually you treat the patient, not the MRI. So it might not correlate with your finding, but always you have to be on the side of the patient and treat the pain. So usually sometimes you will have a significant disc with MRI extruded disc patient doing well. So in that case, you treat the patient, not the MRI.
So, okay, thank you very much. So this will be all for our Q&A session because time is a constraint. Thank you everyone for addressing your questions, for posting your questions here. You've raised some important and interesting topics, and I believe they've been addressed accordingly. So having said that, we'll directly proceed to the quiz. This was the post-CME quiz. 77 of you have attempted it, so thank you all. So the first question reads, which of the following is a positive finding on the straight leg raising test for low back pain? A reads pain in the buttocks, B is pain in the lower back, C reads pain that radiates down the leg, and D is no pain or discomfort experienced.
So the answer for this question is C, pain radiating down to the leg. So we have seen that the SLR is positive. We see SLR is positive when it results in pain radiating down to the legs.
So thank you. The second question reads, which of the following substance is the most abundant in the nucleus pulposus of the intervertebral disc? So A reads collagen fibers, B reads elastin fibers, C reads proteoglycans, and D adipose tissue.
So this is protoglycans. So protoglycans are higher in nucleus pulposus.
Thank you. The third question reads, which of the following would be considered a red flag symptom in a patient with lower back pain? A reads mild muscle stiffness upon waking up. B is pain that improves with physical activity. C reads pain that occurs after eating a heavy meal. D is numbness or tingling in the leg along with lower back pain.
So the answer for this D, numbness or tingling in the lower leg with lower back pain is.
Thank you. The last question reads, which MRI findings are early features of degenerative disc disease in the lumbar spine? A is T2 darkening of the disc on MRI. B reads spinal stenosis with impingement of the spinal cord. C reads disc dehydration and mild loss of disc height. And D is A and C.
So D will be the answer, A and C. So T2 darkening is related with disc dehydration, with mild loss with the earliest degeneration of features in MR.
Thank you very much. So as we've addressed the post-CME quiz, to everyone that has attempted the quiz, thank you very much. You'll receive your respective certificates in a matter of 2 weeks, assuming that you managed to score 50% or more. So we ask that you wait patiently. So having said that, once again, thank you very much, Dr. KIBRUYISFAW. It was a very interesting and engaging topic. So back to you, Dr. Zagga.
Thank you very much, Dr. Adaid. Dr. KIBRUYISFAW, I would like to say again, thank you for dedicating your precious time to teach us about the very much important topic. You can see from the chat box, everyone is really happy. And we hope to see you with another topic for next year. And thank you very much.
Thank you. Thank you, everyone, for your utmost attention. I'm glad to be here always here. Thank you very much.
Thank you, everyone. Have a good night. See you on the next CME session.